Dr. Nardi here, back with another video. Today, we're diving deep into the sometimes confusing, often overwhelming world of psychological suffering, covering everything from crippling anxiety to extreme mood swings. Sometimes, intense fear or sadness becomes so prolonged or severe that it interferes with daily life, signaling a need for intervention. When we talk about anxiety, we are referring to a generalized state of apprehension or foreboding. While a little anxiety can be motivating, like helping us study for a test, it becomes abnormal when it feels completely out of proportion to any real threat, or if it seems to come out of the blue. Anxiety manifests in three main ways: physically, cognitively, and behaviorally. Physical features include jumpiness, trembling, heavy perspiration, and a pounding or racing heart. Cognitively, anxiety involves constant worry or a sense of dread. Behaviorally, this often translates into avoidance or clinging behavior. One of the most intense experiences within this category is a panic attack, often described as a feeling of sheer terror. People often think they are having a heart attack during these episodes, experiencing sudden, overwhelming symptoms like rapid heart rate, shortness of breath, dizziness, and a feeling that they are going to die or lose control. Panic disorder involves repeated, unexpected panic attacks. The leading scientific model explains panic disorder as a vicious cycle involving both the body and the mind. Catastrophic misinterpretations of normal bodily sensations, like a fleeting change in heart rate, trigger intense anxiety, which in turn causes more physical symptoms, escalating into a full attack. For people who experience these attacks, treatment often involves cognitive behavioral therapy, which includes training in coping skills like breathing retraining and exposure to the physical sensations that trigger panic in a safe environment. Beyond panic, anxiety can target specific objects or situations, leading to phobias and excessive fear disproportionate to the actual danger posed. We categorize phobias as specific, like fear of heights or spiders, or social, which is an intense fear of rejection, humiliation, or negative evaluation in social settings, also known as social anxiety disorder. Phobias develop through learning processes. For instance, initial fear, classical conditioning, followed by avoidance, which relieves anxiety and negatively reinforces the phobia, keeping the fear alive. Treatment focuses on undoing that avoidance through techniques like systematic desensitization and gradual exposure. In some cases, therapists even use virtual reality therapy to simulate fearful situations, such as flying or heights, allowing the person to practice coping until the fear diminishes. Then we have generalized anxiety disorder, where the worry is persistent and excessive, not limited to one specific thing. These individuals tend to be chronic, perhaps lifelong, worriers who may feel tense or keyed up. Treatment typically relies on CBT and antidepressant drugs like paroxetine. Moving beyond anxiety, we find disorders characterized by patterns of repetitive and compulsive behaviors. Obsessive-compulsive disorder involves obsessions, recurrent, unwanted, persistent thoughts that generate anxiety and compulsions, repetitive behaviors, or mental acts performed to reduce that anxiety. For example, worrying constantly about germs might lead to repetitive cleaning rituals. Even though sufferers usually recognize their thoughts are excessive, they feel compelled to perform the rituals. The gold standard behavioral treatment for OCD is exposure with response prevention. This technique involves exposure to the obsessive trigger, like rubbing dirt on your hands, while actively preventing the compulsive ritual, like washing, for a designated time, thereby achieving extinction of the conditioned anxiety. Related disorders include body dysmorphic disorder, which is characterized by an obsession with an imagined or exaggerated physical defect, like skin blemishes, leading to compulsive checking in the mirror, or excessive grooming to correct the perceived flaw. Another is hoarding disorder, defined by an extreme difficulty discarding possessions, resulting in cluttered, often unsafe, living spaces. People who hoard often feel an emotional attachment to these accumulated objects and fear losing them. Mood disturbances that are unusually severe or prolonged are classified as mood disorders. Major depressive disorder, or major depression, is marked by a major depressive episode lasting at least 2 weeks, including a depressed mood and or loss of interest or pleasure in nearly all activities. Symptoms also include changes in sleep, appetite, energy, and feelings of worthlessness, hopelessness, or guilt. MDD severely impairs a person's ability to function at home, work, or school. Statistically, women are nearly twice as likely as men to develop MDD. Explanatory models for depression are multifaceted. Psychodynamic theories link depression to anger turned inward following the loss of a loved one. Learning theories suggest depression results from a lack of positive reinforcement. Cognitive models focus on the cognitive triad: negative views of oneself, the environment, and the future, and reliance on self-defeating cognitive distortions. And the learned helplessness model proposes that people become vulnerable to depression if they attribute negative life events to internal, stable, and global factors such as, "It's all my fault," "It will always be this way," and "It affects everything I do." On the opposite side of the mood spectrum, we find bipolar disorder, characterized by extreme shifts between the highs of mania and the lows of depression. Manic episodes feature a sudden elevation of mood, an inflated sense of self-importance, boundless energy, decreased need for sleep, rapid or pressured speech, and often poor judgment. Bipolar I involves at least one full manic episode, while bipolar II involves at least one major depressive episode and hypomanic or milder mania episodes. Treatment for depressive disorders typically involves CBT, interpersonal psychotherapy, or antidepressant drugs. For bipolar disorder, the primary biological treatments are mood stabilizers like lithium and anticonvulsant drugs, often paired with psychosocial therapies to enhance treatment effects. Sometimes psychological stress manifests through disturbances in memory, identity, or physical complaints. Dissociative disorders involve a splitting off of aspects of identity, memory, or consciousness. This includes dissociative identity disorder, which is the emergence of two or more distinct personalities within one person, often linked to a history of severe childhood abuse. It also includes dissociative amnesia, the inability to recall crucial personal information, often tied to traumatic experiences that cannot be explained medically. Somatic symptom and related disorders involve physical symptoms without an identifiable physical cause or excessive concern about the meaning of those symptoms. Somatic symptom disorder features troubling, persistent physical symptoms alongside excessive thoughts, feelings, or behaviors related to those symptoms. Illness anxiety disorder is marked by a preoccupation that one is suffering from a serious underlying illness, despite medical reassurance to the contrary. Conversion disorder is characterized by deficits in motor or sensory function, like paralysis or blindness, that are inconsistent with known medical conditions, often appearing suddenly in stressful situations. Suicide is a major public health crisis and is the 10th leading cause of death in the US overall. It is strongly linked to underlying psychological disorders, most often major depression and bipolar disorder. Key risk factors include feelings of hopelessness and a history of prior suicide attempts. While women attempt suicide more often, men are nearly 4 times more likely to complete suicide, largely because they tend to choose more lethal means, such as firearms. If someone you know is considering suicide, please take them seriously. It is crucial to draw them out, be sympathetic, suggest alternatives to suicide, and most importantly, accompany them immediately to seek professional help. Never ignore a threat. Understanding these complex conditions is the first step toward finding health and resilience. If you or someone you know is struggling with anxiety, mood disorders, or suicidal thoughts, please reach out to a professional immediately. Thanks for watching.